everyone. Thank you for joining me back on my podcast, Gyno Girl Presents Sex, Drugs, and Hormones. I'm really excited to present you guys with an amazing cardiologist. She is amazing, doing a lot for midlife women and women everywhere, really, and actually patients everywhere. So I want you guys to welcome in Dr. Jayne Morgan. She's out of Georgia. So thank you, Dr. Jayne, for joining me.
Thank you for having me. I love it.
So, I just want to get right into it because I've, so
Sure.
many questions that people want to ask and find out about when it comes to their cardiovascular health. And, you've done such extensive work and you're on the media all the time for, non-cardiologic reasons as well, it sounds like. But let's talk about, I discovered you because I've befriended Sharon Malone, during my menopause journey. And so running into her, and she was on my podcast, and meeting her when she came to Chicago and everything. And so I know that's you guys are friends from med school. Is that right?
Right,
Yeah.
right. From our internal medicine residency training at George Washington University.
Oh, wonderful.
Right.
So,
So I was training in internal medicine and she was training in obstetrics and gynecology. We were at the same medical center at George Washington University.
okay, got you. Yeah. So tell me about because, as a gynecologist who does menopause, I'm always looking to find internists and cardiologists who are really in it to and know the data and understand what's going on.
Right.
How did you sort of evolve into this menopause space? Because it's not something, I'm sure, we always say we all had to teach ourselves menopause because nobody taught it to us, right? How did you evolve into the menopause space and midlife women in general?
Yeah, so as a cardiologist, my background is a lot in research. I lead clinical trials. And I was at Piedmont Healthcare leading a cardiovascular research program and later doing research across the system and also innovation. Before that, I was in industry at Solvay Pharmaceuticals, at AbbVie, doing hardcore R&D, research and development, but also medical affairs. So I already had a very sensitized lens to what worked and what really didn't work with clinical trials. Namely, I didn't see women being enrolled, didn't see minorities being enrolled. And even though I was involved in these trials, it was still difficult for me to drive enrollment because the number one reason that people are enrolled in trials is that their physician approaches them. And most Black physicians were not principal investigators of trials, and most women are not. It's dominated by white men, more than 95%. And so I saw this big chasm. And so I always was sensitized to it, speaking about it, trying to move the needle, would do publications. COVID hit, and kind of some of the same things. I really started speaking out about it, was analyzing the data on Moderna, wrote and published a piece, somewhat critical of Moderna, but not enrolling more Blacks in their trials in their phase 1 and phase 2 programs. And somebody at Moderna read it and called me. So I think, these are and I came and I went on to Moderna's credit to become their health equity advisor. So this is the lens that I have always had with regard to women and minorities here with regard to where we are within clinical trials. And speaking about that with COVID, Sharon Malone was also talking about some of the same things in menopause, sort of this whole women's health space. And we decided after she contacted me, she was on actually one of my Stairwell Chronicles. I do something called the Stairwell Chronicles. I post them every Wednesday, sit on my stairs, give you some information about medicine. But I also would do 30-minute in-depth interviews. I would have Dr. Malone on, Sharon. And we decided actually at that point, she thought it was a great idea. She says, why don't you bring some of the cardiology lens to menopause? Because you're already talking about it and you already know something about it. Let's team up together and do that. And we sort of did our first webinar together, and that's how it came into being. So when you look at research, I was so steeped in it, but I could see really from a very specific lens as a Black female physician that we were never enrolling women. We were rarely enrolling minorities, but that's a lens that most people don't have. You don't see people like me
Absolutely.
leading research. And so it's a little bit of group think, right? One person reinforces the thoughts of the other and everything is working fine. Doesn't necessarily mean that people are racist or biased. They just don't invite any other perspective, so they don't really know where to grow or what's missing.
Right.
And that's part of our challenge in this industry. And that is where bias comes into play, that people that look like me and people that look like you, women and also minorities, don't get elevated into positions where you have a seat at the table and you really can bring that 360-degree lens. And so while individual people may not be biased, the system is
This
biased
uh,
and moves the lens towards men to the detriment of healthcare of women and minorities. And so I spoke about that a lot.
mhm.
And then during COVID, it became even more evident. And then Dr. Malone, Sharon, my friend, was also joining my alloy, talking a lot about menopause and women's health and the disparities in women's health. Here I was talking about it as well from the perspective of clinical trials and research in cardiology. And then I had her on my sort of webinar called the Stairwell
I
Chronicles.
love those Stairwell Chronicles, by the way. They're awesome.
So I would, every Wednesday now I publish them, just 60 seconds. I give some information about medicine. But from time to time, I'll do something for 30 minutes. I'll have a guest on. We'll do an in-depth interview. And I had Dr. Malone on once. And afterwards, we were talking, and it was really her idea. She said, you're really working in this area
Mhm.
in cardiology and women's health. I'm doing a lot from the gynecologic perspective. I think it would be great if we teamed up and gave this information because we really are working on the same things. We don't need to be in two different silos.
Yeah,
And that's really how I started to become drawn into the menopause world. I was already speaking out as a women's health and a health equity advocate with regard to what I was seeing from the research perspective and clinical trials perspective and how people were treated as you come into the doctor's offices and leaving with more questions than you came with and not feeling
yeah,
empowered to ask questions and just
absolutely.
not getting health care in general. And so
Yeah,
that's really how it started. I think you already have to have maybe a passion for it, an
yeah.
interest in it. And that's kind of where I was. I was already, I have been able to provide a cardiology lens to the whole topic of
Mhm.
menopause, and midlife women.
I love it because we're gonna get into that lens in a minute. Um,
Mhm.
Tell me though, like, you and I are so aware, like, heart disease is the number one killer in women. We don't hear about the heart enough. I mean, we have the short month of February for heart disease
Right.
where you go around for 28 days. But
That's
the
right.
reality is, like, more women will die from heart disease than they will of breast cancer, any of the cancers. But
Right.
what do you think? Is it just a PR issue, or like what's happening? Why are not people not aware of this? And other than people like you and I speaking out for menopause and cardiovascular health, but where do you feel like it's lying right now?
So, women generally develop heart disease about 7 to 10 years later than men.
Mhm.
Because of that recognition, there has been a misperception that heart disease then is a disease of men and not of women.
Mhm.
And that message has just been relayed from whatever, generation to generation, doctor to doctor, person to person, patient to patient. But that's not really true. As you've already stated, heart disease is the number one killer of women, no matter where it starts. In fact, one woman per minute dies of heart disease in this country. In
Grounding. Wow.
fact, 1 in 5 women has heart disease as opposed to breast cancer. 1 in 40 women will be diagnosed with breast cancer. And yet, breast cancer has received much more visibility because it's so specific to women, and heart disease has the perception of being a disease of men. You add to that that our symptoms can be more subtle of a heart attack than that of a man, and that our symptoms are characterized with this word atypical. And that word drives action and drives thought, and
Words
and
matter.
others, the person who gets described as atypical, others their symptoms away from the mainstream. And there you have it. We see a delay in women receiving medical care. We see a delay in women even reaching out for medical care. We see a delay
Mhm.
in getting women even to the cath lab. And we know every time increment of a delay to the cath lab is an increase in mortality and morbidity. And so we see these delays cascading. And it's the reason why Even though women's heart disease starts later, 7 to 10 years later, the first heart attack of a woman is more often fatal than that of a man because of all of these built-in delays,
Mhm.
because inherent bias and mislearning by our system, by physicians as well, and then what goes out to the general public, what people think of as heart disease. So a woman can sit at home for a long time with symptoms of heart disease. She might have nausea, not be
Mhm.
feeling well, have flu-like symptoms. Jaw could be hurting. She's got back pain. She's laying down, putting a heating pad on her back, taking some Motrin. And the fact of the matter is, you're having a heart attack.
Yeah. But it's in
And
her head, right? Not in her heart.
and then she comes to the medical establishment. You don't have the classic symptoms, and they may use that term atypical chest pain. They use it at all. They may just say she's got anxiety, she has
Yeah.
depression. They do the there, proverbial there, pat you on the back, there,
Yeah. Yeah.
home, rest, that type of thing. And that's what we really have to stop. And that's the drive, and that's the reason why breast cancer, which is clearly more targeted and relevant to the female population than the male population. So that message could not be muddied by
Mhm.
gender discrimination as opposed to heart disease, right? Everybody has a heart. So this seems
Everybody
like
has.
that's a male problem. So, when you think about things like the vagina, the uterus, the cervix, the breast, women get to own that, right? I guess to be our
Yeah.
space.
Yeah.
But then when you talk about the
Yeah.
heart, oh, I don't know. Do women even have hearts? Do we have lungs? I'm not really sure. It seems
What's going
like
on in
that's
that?
a problem, you
That's
know?
yeah. Yeah, absolutely.
Yeah, yeah.
And speaking of all of that, we always say, in health, we always say sexual health is health because when, as a sexual medicine gynecologist, in the male world, of course, erectile dysfunction might be the first sign of something happening,
Right.
either cardiovascularly or diabetes. And we see this
Bingo, and most
with,
people don't know that. That is such a great observation to make. I know we're talking about women, but
right,
erectile dysfunction could be the first sign of heart disease in a man. So think about that before you pop the Viagra. Maybe
yeah.
you see a cardiologist because this could be a sign that you actually have heart disease.
And what we're learning actually in the female sexual medicine space, and there's more research going toward doing like ultrasounds and blood flow to the clitoris, is the same thing. Like, of course, vascular compromise in these small vessels are going to show up first. Okay, so I'm South Asian, and so I have a vested interest in my cardiovascular health because, as you know, I don't have to tell you, but I'll tell my listeners that we make up 25% of the world population, but like 67% of the world heart disease or something astounding like that. So, I mean, can you talk to my South Asian listeners for a second about heart disease and prevention and what you see or what you might know about why that is more the case? I mean, I know there's a lot of theories about whether or not we talk about this with Black women as well, the allostatic load of having, you know, a systemic racism, and I think the same is sort of viewed in the South Asian culture, like the hundreds of years of colonization, induced famines, and such that occurred under the British Empire. May be translated into a change in our vasculature and our epigenetics. Can we talk a little bit about some when it comes to women of color and how we treat that a little differently?
We can, and a couple of things. We call that the weathering process, and actually there's some science. Weathering meaning just kind of just as it says, like the erosion of, think about siding on a house, just starts to get weathered and run down. And the reason for that is it's termed high impact coping. So high effort coping. So constantly having to be in an alert state of vigilance, so looking over your shoulder, thinking about what you're saying, how you're being perceived, how you're being judged, whether this is a risk to make this comment or that comment, or even go into this neighborhood or that neighborhood, how you raise your children, especially your black
Mm-hmm.
sons, targets, how even getting a driver's license for your son is a time of joy, but also trepidation for a Black family, how
Yeah.
choosing your physician is based on trust, who can you trust first, which is why 80% of the Black population is seen by a Black physician, because first, we're the only race that chooses a physician based on who will not do us harm first.
Mm.
All of those things wear you down over time. It never goes away. It's an every single day part of your life. And then when you think about going into job situations, trying to get hired. Once you get hired, you can only get promoted as high as middle management. You're never able to go higher, even though Black females are the highest educated demographic in the United States.
Mhm.
We get the least amount of upward mobility
Abs
because we're not groomed, we're not moved forward, we're not seen as being worthy of having a seat at the table. As I like to say, we're not deemed worthy of having that Black job, right? So that job is really, let's talk
Not
about what the Black job really is.
right.
And so that moves on. And then there's science behind it. So there are telomeres, right, on our
Right.
DNA. And the end caps, we have DNA, and the end caps of those DNA have telomeres. And the length of the telomeres is actually correlates with aging. And the longer the telomeres, the younger the person. As you age, those telomeres shorten. When we look at Black women, they tend to have shorter telomeres in comparison to other races. In fact, they appear to be about 10 years older biologically, meaning your body, than chronologically than your age.
Mhm.
So a big question I have then is, should women, Black women, when they come in, be actually screened and offered testing based on your biologic age that has been advanced because of all the racial, demographic challenges that we face here in
Yeah.
the country, as opposed to your chronologic age? Should all of our screening processes actually be moved up 10 years earlier? Because that's how old our bodies are.
Yep.
And and so that's what you talked about when you talk about the allostatic load is called the weathering process,
Mm.
right? High effort coping at all times. Other races have it, just as you said, with the South Asians. And I'll tell you something else that we have in common when we talk about familial or genetics. There's something called a cholesterol, a very specific type of cholesterol called LP little a. It's LP parenthesis A
Oh,
parenthesis.
good. You're okay.
This type of cholesterol actually confers the highest risk of heart disease of any other type of cholesterol, and we see it more commonly in Blacks and in South Asians. Now, why haven't you heard about it? Because we generally don't test for it. Why don't we test for it? Because we have no treatment for it. So generally, doctors don't like to test for stuff that they can't really give you any
Right.
therapy for.
Right.
We do have therapy hopefully on the way. So I happen to be on the steering committee of Novartis for the Horizon trial, where we're developing therapies for the LP little a. We've been working on this for a few years. So in
Yes.
2025, we should be closing these phase 3 trials out, and there may be something coming. But in the meantime, don't step away from asking to have your LP little a drawn, because if it's high, generally that means over 30. If your value is over 30, then your doctor can begin to work with you with intensive therapy. That would mean aggressive lowering of your cholesterol, LDL down to less than 50,
Mm.
aggressive lowering of your triglycerides, aggressive management of treating your hypertension to goal, really encouraging that exercise 30 minutes per day, according to the American Heart Association. That's going to be important for you. If you are smoking, just stop. If your LP little a is high, if you've got diabetes, it is time to get it under good control. If you are overweight, we got to start to work on that. So really, it's going to be even more important to you, and you would work more closely with your doctor and a nutritionist and a dietitian to really work on those risk factors,
Mhm.
heart disease, because your genetic propensity puts you at increased risk of having a heart disease. So you've got to take these other traditional risk factors even more seriously.
Absolutely. And speaking of chronologic versus biologic age, I think it was in JAMA a couple weeks ago that an article came out that showed, hormone replacement therapy reduced your biologic age if used within 10 years or something like that. And it was more significant in women of color. So is this maybe? I mean, let's talk about hormone therapy for a minute, which is we talk about a lot here: estrogen, estrogen plus progesterone if you have a uterus. And we don't use it for primary prevention of heart disease. We use it for primary prevention of osteoporosis and symptoms. But where is your thought on this? Like, is this something we should consider?
Yeah, and this is certainly evolving. You hit the nail on the head. Back to where my bread and butter is, right? Clinical trials and research. All these questions, we don't have the answers.
Hmm.
We have the thoughts because we know how things work and we know the mechanism of action, and we can draw conclusions as to why estrogen is important because we've got all these receptors in our body. And once that estrogen level drops, we see the what? Rise in cholesterol, because estrogen and cholesterol are both metabolized in the liver. We see the rise in hypertension. We know that a drop in estrogen
Hmm.
increases vascular stiffness, raises that blood pressure. We see insomnia developing. We know sleeplessness is a risk factor for heart disease. So we can make very educated assumptions
Yeah.
with regard to what's happening to
Yeah.
our heart. Unfortunately, what we don't have is that hard data. Why? Because research doesn't focus on women, and then even on research that is not women focused, we don't enroll women in those clinical trials. So all of this is yet to come. Now, all of those things with estrogen are true. We know that estrogen increases collagen and elasticity in the skin. Doesn't mean take it for vanity reasons, but that's just something to talk about.
Hmm.
Um, we've got estrogen receptors in the heart. Estrogen is an anti-inflammatory agent in the heart. We know that inflammation is one of the risk factors for heart disease. Inflammation is also one of the risk factors for cancer. Inflammation is also one of the risk factors for arthritis and autoimmune diseases, and
That's
on and on and on and
Yep.
on and on.
Yes.
And so there are a lot of good reasons to take estrogen, and that body of evidence is starting to emerge. What we still haven't seen are these really large, double blinded, randomized clinical trials of thousands of patients. And you know
Mm-hmm.
why? Because they're very expensive,
So, yeah.
and women don't lead these drug companies, and women don't lead these clinical trials, and we are not controlling the purse strings. And
Yep.
so this is really a movement that we have got to push forward because data is what we really need to have. Now, do we have data? We have data, and we have it on small trials and small pockets, and we have sponsor initiated data, but we need to have big randomized clinical trials. But the data that we do have on estrogen is good data. And it is good data as well on women. Estrogen may not be for everybody,
Hmm.
but when we're talking about controlling the symptoms of menopause, we know that the symptoms of menopause are not innocuous, meaning they're not nothing.
Yeah. It's not
Because
just a hot flash.
that's right. Those
Yep.
symptoms are actually have an association and a correlation with heart disease and with stroke.
Mm.
And so we've got to begin to take those seriously. And what does that mean? And how do we begin to come back to our whole selves and reverse the data of a woman's risk of heart disease equaling that of a man as we go through perimenopause? That's because cholesterol increases, hypertension increases, sleeplessness increases, on and on and on. And then next thing you know, and then on top of that, we've got those quote unquote atypical symptoms that we don't
Right.
recognize. And
Right.
the next thing you know, we have a heart attack. Remember what I said? The first heart attack is often more often fatal in women than in men, right? So that's
Absolutely.
why one woman per minute dies of a heart attack in this country. She may not even be aware that she had heart disease.
Absolutely. Um, going back to the idea of more clinical trials, I mean, the reality is, when it comes to women of color, South Asians, African Americans, all the things, like we're just not in that many trials for many reasons. I think there's a bias that exists. We know implicit bias is there, but we also know that there's distrust of the medical community. How do you
But for good reason. You
Yeah.
can't blame
Absolutely, absolutely. I always say that, and I agree that I understand why it's there. I
Right.
mean, other than just speaking out and educating, how else can we overcome that? This is something
So
I have long
yeah.
conversations with my patients about.
the way that can be overcome is the drug companies and device companies need to recruit physicians of color and women as principal investigators of these clinical trials. 98% of principal investigators are white men. They dominate this area. And the number one reason that patients enroll in a trial of any race, gender, creed, color, religion is if they are approached by a trusted physician. 80% of the Black population is seen by Black physicians for that trust reason.
Yep.
So if 80% of the population is seen by Black physicians and almost 0% of Black physicians are leading clinical trials,
So
you
true.
can see why we've got a
You
little bit
guys
of a
saw-
struggle
oh,
in getting people enrolled. And again, this is why I said it doesn't mean that individuals are biased, but the system is biased. And then individuals, I'm not letting individuals off the hook. Individuals perpetuate
the
the
bias.
system
Right.
even long after they know better. They
Yeah.
continue to perpetuate it. You know why? Because it works for them.
Right.
It's not my problem. I've got enough problems. That's not my problem.
Right. No, it's true.
Right.
And we're trained in that system, right? So if you're trained in a system where you don't listen to patients or see them for who they are, then you're not going to change the system. And so I
That's right.
think I always talk out against implicit bias for this reason that I see it, and we've all probably been, a victim either of it or have done it and it's implicit,
Or
right? It's not
observing it, right? In
observing.
our med school and in our training, you're going, what is going
I,
on? They just say that to these
yeah,
patients? What is
exactly.
happening?
What- And that's not even implicit. That's explicit bias, right?
And
Right.
then what do you have? You don't have the power, so you just keep your mouth shut and you're
Mhm.
thinking, what the heck?
But it
Right.
stays with you as I mean, I
Right.
had so many
You can't see it. You can't unhear it.
Yep, yep. I mean, I had when I was a first year intern, had someone talk about a South Asian who had vaginismus, and she asked me like, what's the deal with your people? They act like they've never had anything in their vagina. Like
Right.
she
Right.
literally said that to my face as an
Right.
intern, and she was a senior attending, and I was like, did this?
Right.
And it's still 18 years later in my head, like when I think about it.
Mm-hmm. Mm-hmm.
So, I
Yeah.
mean, it's there, and so unfortunately, we have to be able to either call it out, which if you have the intestinal fortitude to do it at the time,
Right. Right,
or
and it's this, when you are also a cog in the wheel of the system, you are a lowly med student or an intern or a resident. You depend on these senior people, to give you your recommendations, to get you to the next level, you can finish the program, blah, blah, blah. And so it's always a risk to
Mhm.
speak up. Should I speak up on behalf of this patient? Because this is going to make sure this patient has a better outcome. But if I speak up, am I putting my personal,
career. Yep.
career at risk? And if I can't be a physician, then I can never be in the system to make it better.
It's
So
the
let me
catch
just keep
22.
my mouth shut until I can get to a place where you speak. And then when you get to a place where you can speak, you realize that's not a place you can speak either. And
Yeah.
then you get to this place, that's not a place you can speak either. And then you start to realize, oh, the whole system is not a place
Yeah,
where
exactly. True. It's sad.
I have no
For sure.
power. So yeah,
Yeah.
absolutely.
The other question I was going to talk to you about is sort of some of the evaluations we do. So, oftentimes I'll have a patient who, um, well, we know like premature menopause and primary ovarian insufficiency, again, more common in women of color, Black women in the United States. And so sometimes, if I find someone who's been sort of remote from menopause, but now wondering if they can, like 10 years later, be in this menopause hormone therapy journey, I will often then get, a calcium score and a CIMT. And so, can you talk about some of these evaluations because people are
Yeah.
wondering
I
about?
mean, yeah, so we're thinking, there's a window of opportunity to
Mhm.
start hormone replacement therapy if you're going to do it. That window of opportunity is 10 years from your last menstrual period. So when you entered menopause. Beyond that, the reason that there's that window is that estrogen therapy can increase your risk of heart disease, or I won't say that, won't increase your risk of heart disease, can increase your risk of a cardiovascular event if you already have heart disease. Now, Why do we use that 10-year window? Because after between the ages of 60 and 75, most people in the United States, 70% of people in the United States already have established heart disease. After the age of 80, 85% of people already have established heart disease. So that window of opportunity is why we talk about that. Here's the other caveat to that, just to make it even, like more complicated.
Yeah.
So that if you're in year 11 and you start hormone replacement therapy, it increases your risk of having a cardiovascular event because you've got a 60 to 75% chance of being in that group, which is the majority that already has established heart disease. If you decide to go ahead and do hormone replacement therapy in year 11, after year 11, your risk goes down.
Yeah.
So
It's like that 1 year. It's right.
there you are. Another area, again, so many areas where we really need to get much, much better information, but that's the information as of today, and that's the thought on it. Now, in year 11, if you're seeing a physician, a menopause physician, or someone who's interested in menopause or actually understands what's happening in women's health, just as you said, maybe you can get a calcium score, which is not an intervention. It's not a procedure. It's a test that we don't then act on with a procedure. It's a risk. It gives us an assessment of your risk
Mhm.
over the next 10 years. So some people think, well, I get a calcium score and after that, I'm going to end up with surgery. No, no, no. This is not anything that tells us whether you're going to surgery or not. This is a risk stratifier, especially if you are asymptomatic. Now, if you have symptoms, then, you probably don't need a calcium score. You probably need to go to, a CT angiogram or something. But this is just for the asymptomatic, let's say the asymptomatic woman,
Right.
no family history of heart disease, but beyond the window of menopause, a reasonable place to start maybe in getting that calcium score.
And then also, we're looking at the carotids similarly is the same thing, looking for stroke risks, right? Um, uh, what is and what so uh, when they score them, it's like you have either zero to 1,000, right? Is that the scores?
Mhm. Mhm.
And moderate to severe risk is usually, is it above 200? I can't remember. Is it above
You
200?
talking about calcium score?
Mhm.
Okay, so calcium score, what you want, believe it or not, is a 0.
Right.
Even a 1 or a 2 for these purposes, just to be high level, is positive, right? So
Okay.
you want 0.
Right.
Now, of course, the higher your score, the more positive it is. But even a 1 is positive, a 2 is positive, a 200 is even more positive, right? You've got more calcium, but a 1 is positive. Really, normal is 0.
Right.
That's how calcium is scored, right? And if you have anything other than a 0, then that is,
Awesome.
for lack of a better term, a positive calcium score. And then you and your physician can talk about what you want to do from there based on what your goals are. If you're trying to start hormone replacement therapy, or if you needed to just understand your risk and institute some really aggressive risk modification strategies at that point, including, high dose cholesterol, anti-cholesterol medicine, all those kinds of things,
Mhm.
medications. Um, so that's it. A calcium score of 0. That's the only thing you need to know. It's
Okay.
either 0 or it's
A positive. Okay, gotcha. Yeah. Um, and for most people, if they have like a moderate to severe risks, like most people wouldn't like move beyond that, I think, in terms of hormone therapy, unless, the patient really, right? What'd you say?
yeah, I would say that unless you're already on it. So if you're already on hormone therapy,
Right.
yeah.
Right.
So it's right. We probably would not institute if you've never been on it, and then you've got this higher
The
calcium
house.
score. Right.
Right.
Right. Right.
Okay, cool. Okay, so my last question for you is, what do you tell your patients, especially women of color, who are finding it difficult to find, because my tagline is, "I'm here to educate, so you can advocate for yourself," right?
Right.
So I think like I'm always trying to figure out like how to help them navigate the system and all the things. But as a cardiologist, from your perspective, how would you like really, tell any woman, women of color, any woman in general, but specifically women of color who might receive more bias, like how to better navigate the system or how to find someone that will listen to you?
Right, and that is a challenge, and
Mhm.
I encourage people, to doctor shop. But certainly you can look up doctors who are certified, who have the menopause certification. If that's a question that you have, you don't have to give up your doctor. You can get a second opinion from
Mhm.
someone with the menopause certification. And again, it doesn't mean that you have to see this doctor for everybody who's just seeking hormone therapy. You may want to see a menopause certified physician or specialist just to get information. There's nothing wrong with getting information such that you
Mhm.
can make a decision that is the best thing for you.
Yeah, absolutely. Okay, thank you so much, Dr. Jane. I really appreciate this
Sure.
conversation. I want to be cognizant of your time. Are you going to be at the menopause conference this year, or were you not able? Okay,
Sorry.
okay. I was like, oh, we could meet up in Chicago.
I know.
Well, hopefully, I'll get a chance to meet you in real life one day. But I really appreciate you coming on to lay some information to my listeners and viewers. And I'll continue to watch your Stairwell Chronicles
Yeah.
and your Instagram. And you're all over the news all the time, like dispelling myths on COVID and all the new
Just
viruses popping up all over the world.
any medical topic I talk about, that's okay. I mean, what I work on is making certain that I can explain it in a way that people understand.
Right.
And that's why I do a lot of these medical news interviews on any medical topic to make certain that people walk away with a good understanding of the topic and a good understanding of how to protect their health. And you guys can follow me. I'm on Instagram, Dr. Jayne Morgan. That's just DrJayneMorgan. I'm on Instagram, also on LinkedIn and X and Threads. So, any
We'll pull all the handles on the show notes for you, so where you can
come
find Dr. Jane.
on over
She's
and follow
everywhere. Dr. Jane's everywhere, so she'll find her
along.
somewhere. But we'll put all the information there, and I appreciate you being here today. Thanks for listening today, guys, to Gyno Girl Presents Sex, Drugs, and Hormones. Remember, I'm here to educate so you can advocate for yourself. Please join me next week for another episode. If you have a second, please subscribe to this podcast. I'd love for you to be a follower and learn as much as you can about the things that we're going to talk about with all the people on our journey. Please review us on Apple or Spotify or wherever you listen to podcasts. These reviews really help. Review us, comment, tell me what else you want to hear to get more information. My practice website is www.cgcchicago.com. My website for Gyno Girl is www.gynogirltv.com. My Instagram is Gyno Girl, so please follow me for some good content. Additionally, I have a YouTube channel, Gyno Girl TV, where I love to talk about all these things on YouTube. And please subscribe to my newsletter, Gyno Girl News, which will be available on my website. I will see you next time.